Dear ladies and gentlemen, it's my great pleasure to be here today with you, unfortunately only in this virtual way because due to the circumstances I was not able to travel. So I hope next time it will be possible to see and to meet each other, and now I would like to thank you, the organizers, for their kind invitation and congratulate them for organizing such an important and successful meeting. My part would be to discuss a little bit about the importance of wide view concept in the treatment of hypertension, which I think it's needed in our daily practice. So, when we talk and discuss about present facts of hypertension, then we can say that hypertension is controlled in less than a fifth of patients worldwide. We can say that detecting hypertension early and taking measurements to control is a cost-effective way to reduce the hypertension-related disease burden. There is no easy way to measure blood pressure, but it's important that we do it. Once hypertension is diagnosed, treatment can be lifelong and regimes are relatively arbitrary and not precise and often comes with the side effects. Effective, inexpensive blood pressure-lowering drugs are offered to and regularly used by only a fraction of patients who need them. The complete pathophysiological and genetic way of primary or essentially hypertension still remain unclear. And diagnosis based on blood pressure measurement also neglect the many factors that influence blood pressure, such as social, behavior, and dietary and physical activities, and some other variables. And those are the ones which I would like to talk about today. So when we think about long-term prognosis, then we have to know that we have to take in account patient personality, a meaning of life, personal attitude, occupation. Of course, we have to know all the medical facts and about the medical therapy. But then on the end, it's important that we have right communication with our patients. And due to the fact that this is long-term treatment, and often we forget about those things which I will try to mention. So talking about definition of health, we say that this is according to World Health Organization, a state of complete physical, mental and social well-being, and it's not merely the absence of disease and infirmity. So when we talk about good health, then we also talk about good life. And it is important that we think what is the meaning of the life for our patient, because this is what we are trying to heal him. This is what we try to help him, that his life will be better, that his health will be better. And I found quite a nice movie on YouTube, which I recommend you to take a view. And unfortunately, I cannot put it in here, but I will just say that point of this view is that we have to think about the communication, about understanding, and about the service which we can offer in our life. And all these completes the meaning of somebody's life. But of course, everybody has a different view on the meaning of life. So it is important that we know what is our patient's meaning of life and what does he want to achieve in his personal life. And that's why it's important that we discuss about that and that we can encourage them in that sense that the meaning of life for them will be different if they will be in a good health. And of course, it's important that we know what is the personal attitude of somebody's. As you can see, 50% of the patients are not adherent to antihypertensive treatment. Of course, they are adherent to the treatment which is like they say useful for them. For example, if they have pain, they will definitely take painkillers. But due to the fact that in hypertension they do not feel anything, at least at the beginning, the adherence to hyper-2 treatment is quite low. And you see even lower is for statins. Therefore, we have to do something to encourage their adherence and try to raise the proportion of patients who are taking tablets regularly. As it was noticed in one database, which included about 10 million residents of the northern Italian region in Lombardy, it was seen that about 62% of the people discontinued their treatment for more than 3 months. And you can see that adherence in different age groups is somewhat different, but it's always slow. So it is even lower in the high ages group. So I think it's one of the points which we have to address, how to raise, of course, the adherence. And when we talk about lifelong treatment, then of course we have to know what people are doing for their life. What is their occupation? Why do they need to stay healthy? And how do they have to earn their money? And it was interesting for me to find this study which compared, you see, a huge number of firefighters who are comparing to the frequency matched sex and age controls in the reference group. And as you can see, they were more than 40 years old, and the number of them who were included was high. And when they compared this group to a normal match controls, they found out that the major adverse cardiovascular events were much higher in the group of firefighters, as you can see. So you can see here the number of MACE. So the risk comparable to the match controls, which was much higher, comparable to myocardial infarction, as you can see here, and ischemic and hemorrhagic stroke, as you can see, were really, let's say, 2 times or 3 times higher than in the normal population. So, as you can see, it is important that we come to the target blood pressure. And if we look to now the latest guidelines from 2018, we can see that in most of the ages and most of the patients, this target number is 130/75. And it's really necessary that we go in direction that we will come to this target blood pressure. So of course we have to use the antihypertensive therapy. And still in the first line we have 5 groups of drugs which we can combine. And then most of the times we also have to use other 2 groups which are not so often used, are central acting drugs and also alpha blockers. So these are the 2 groups of the drugs which are not used so often, but definitely they are necessary to be used in some of the patients. So of course we can still start with the monotherapy, but we know that monotherapy is not so successful. That's why we have to go for the combination therapy, and if it's possible, we try to combine in one single pill. Let's say starting in 2 dual combination, IC or RBs, in combining preferably with CCBs, and if that is not possible, with long-lasting diuretic. And then in the second step, we go for 2 combinations where we have to include this long-lasting diuretic. So this is step 2. And then we have a step 3 where we have to usually need 2 tablets, so 2 pills, and we have to combine it with spironolactone. But we can also use smaller doses like 12.5, and then we slowly rise it to a higher doses if it's necessary. Or we include some other long-lasting diuretic or alpha blocker or beta blocker. And we know that beta blockers are often used if it's necessary when we have combining also comorbidities beside hypertension, which need to be combined with beta blockers. But as you can see, the combination, the percentage of people who is on the combination therapy is still quite low. It's going from 33 to, let's say, 45%, depending on different countries. But in most of the times, or more than 50%, people are still in the monotherapy, which of course is not so useful to reach the target blood pressure. And there is another point which we have to address when we think about medical therapy. We have to know that medical therapy should be regulated through all the periods, through all the lifetime period, because sometimes let's say the doses of drugs are too low, and that's why we have to rise it and we have to adapt the treatment. Because as it was noticed in the study recently published, if the variability of blood pressure, so what variability is simply seen, so variability means that the blood pressure is not controlled in all that period. Then it was seen that also the hazard ratio of events was much higher, as you can see here, and also that the changes on hypertension-mediated organs was bigger comparable to the one where blood pressure was more controlled, so it means that variability was lower. So that's why in many times we have to control the blood pressure with different kind of therapies, and we have to adapt the therapy. So sometimes we have to go from the double therapy to the triple therapy, and many times we can also notice if, for example, here we change from AC to in combination of diuretics to the combination with amlodipine and ACE inhibitor, then we can see that the control rate is, let's say, 81%. But if we change it from ACs to ARBs and hydrochlorothiazide and amlodipine, then we can see that it's 91% controlled, which means that sometimes it's useful to come from ACs to ARBs, also in the combination, or vice versa, because in that way we control the blood pressure in a different way, and that's why it's important that we also have that, keep that in mind. So when we were talking about single pill combination, quite a lot of studies were done and looking what is the adherence to single pill combination. And as you can see in different trials and also in cohort studies, of course, the adherence with the single pill combination was much higher in comparison to the different drugs in different regimes. So single pill combination definitely is better for the adherence. And then often we doubt how many times should we see this patient. Usually we do not have enough time, and in other times we say, well, does it really matter how often do we see him? But as you can see in this study, more often patients were seen, their blood pressure was better controlled. So shorter interval between visit patient doctor were faster to normalize their blood pressure. But of course it all depends how much we can afford and how many visits we can do for our patient. But of course we can also do it in other ways to control the blood pressure. And when we think about the effect on hypertension-mediated organs, we can see that in this large study, when they were looking for the patients who visited the emergency room and they were looking for the mortality rate, they found out that the patient where the hypertension organ damage was present already, that the mortality rate was much higher in comparison to those where hypertension-mediated organs were not affected. But do patients really want to take tablets? It was interesting to read about this study, which was published in some years ago, when they asked a lot of people if they would trade their lifetime with not taking cardiovascular pills. So it means if they would not take cardiovascular pills, how much time they would change for this life in their lifetime. So as you can see, let's say the majority or around 70% of the people, they replied that they would not change any of that life of their life for the not taking tablets. But on the other hand, it was about 8% of the people who were willing to trade the 2 years of their lifetime for not taking the tablets, which really means that people do not like to take tablets. But on the end, let's say that probably hypertension, we need transformation. We need to see how to go into digital transformation. We have to seek about including artificial intelligence in, let's say, controlling our patient. We need to perform population science transformation. And of course, it's important that healthcare delivery transformation will be changed for the future. And of course, biotech and biomedical transformation will be done. But still, this is for the future. So for now, we have to think about patients in a wider range, in a wider view, and we have to, let's say, discuss with them properly. And I think one of the points which was interesting is that, let's say, from 17 to 20% of hemorrhagic strokes among hypertensive patients would have been prevented if they had been on hypertensive treatment. And I think this is a very strong statement, which if you would face your patient with, I think he would be really thankful to you and he would take the medication as you will prescribe it. So I think that we need to widen our let's say treatment and our thinking about treatment. We need to think about patient personality and its meaning of life. We have to think about his personal attitude to our treatment. We have to think what is his occupation, what is a real medical facts, what are the real medical facts about medical therapy, and on the end, we need to have right communication with our patient. And with this, I would like to thank you for your attention and hope